Hi, I'm Rebecca Maniago, Senior Director of Oncology Care Pathways at Viz.ai, and it's my pleasure to welcome you to this episode of the Vizion Expert Series, a podcast where we speak with the visionaries shaping the future of healthcare AI. This is where deep healthcare insight meets real-world patient impact. Joined by my co-host, Tim Showalter, Chief Medical Officer at Viz. We're talking with the experts who are not only innovating, but also implementing AI in ways that are transforming care delivery for both patients and providers.
And today we're speaking with two of my favorite leaders in prostate cancer and medical innovation. Dr. Adam Dicker is a nationally recognized expert in prostate cancer and translational research at Jefferson Health and the Sydney Kimmel Cancer Center, who is known for driving clinical innovation in radiation oncology and the use of digital health tools to track patient outcomes. Speaking with him is special for me as Adam was my department chair for my radiation oncology residency and first faculty position at Thomas Jefferson University. He's joined by Dr. Paul Yonover, a board-certified urologist and partner at Uropartners with more than 25 years of clinical experience. A leader in advanced urologic care and research, Dr. Yonover specializes in robotic surgery and prostate cancer treatment and is a passionate innovator focused on implementing new data platforms, technologies, and precision medicine at scale. Adam, Paul, welcome to the Vizion Expert Series.
Thank you.
Thank you.
I'll just mention it's always nice to see the graduates far exceed whatever the chair has accomplished. So we're very pleased at Jefferson with your role at Viz.ai.
Well, thank you.
Thanks for having me.
Awesome. So I'm excited to hop into this discussion. Really, we're going to kick it off with talking through some of the current challenges in prostate cancer. And Adam, I'll start with you. When you think about prostate cancer care delivery in 2026, what feels most unsolved, clinically or even operationally?
Well, there has been a data explosion. There are more therapeutics that are available to the clinician. Keeping track of that is challenging. NCCN guidelines are moving. And then I think one thing that I see, because I do a variety of things nationally, is there's a lot of variation of care. And I think that there's, whether it's within urology, radiation oncology, or medical oncology, and I think part of that depends on what ecosystem you have at your local community hospital or academic center, because the ultimate quality is really multidisciplinary, right? If there's a weak link between urology, radiation oncology, pathology, medical oncology, supportive care services, social work, et cetera, imaging, radiology, etc., you're going to not have the optimal outcomes for patients. And then layered on top of that is there are a lot of cognitive biases that everyone brings to the table. There's a fantastic book called Random Acts of Medicine by Bapu Jena and Chris Warsham that kind of looks at some of the heuristics, the shortcuts that physicians use. And I see this all the time. And I think there are great opportunities for AI to democratize advances in technology and to level the playing field, whether you're in a remote area or whether you're in a busy urban area. I think reducing the cognitive biases and the heuristics that physicians sometimes bring to the table is another opportunity. And then there are some opportunities to deliver more efficient care, et cetera.
Yeah, Adam, that's a great sort of overview, and just to like reflect on that a little bit. I think your perspective is very like well experienced in this area because you oversee a department that's spread across many different care sites. And of course, there are many different physicians who may see patients with a single, type of cancer. And then, as you pointed out, there's this multidisciplinary nature. And so you've got, provider preferences for how they want to approach different patient care flow among those different sites. And I can imagine it's a pretty complex task to try to move towards uniformity in care.
In my sort of world, being in private practice, large group practice, which is huge volume now in the United States for a care delivery model, all of those things apply and are magnified to an extent, because we have pathways in order to try to do exactly what Dr. Dicker is saying, follow NCCN guidelines and follow well-established, accepted practices and try to reduce those variations of care. We have hundreds and hundreds and hundreds of providers now, and we have tens of thousands of prostate cancer patients. So, I see things through the eyes of just from data. So, right now in prostate cancer 2026, we have an explosion of the complex data associated with a prostate cancer diagnoses, right? Germline, somatic, mutation analyses, PET scans, MRIs, and the like, where we're no longer practicing with just PSAs and Gleason scores. That has happened at a point also where we're trying to homogenize to an extent how our providers are using data to drive decisions. And then on top of that, try to, accomplish population management and try to achieve some, clinical research if you can on top of all of that. And so I would say what's so daunting and so promising is the volume and complexity of data associated with one diagnosis. And it just so happens that we're living now in an age of AI where we can leverage that, manage that, and not be drowned in the data, but actually do what it's there for, is to take advantage of it.
Just to add a little color to Paul's work, I think now as patients live longer, we're aware of, in many cancer areas, but particularly in prostate, there are some long-term tox issues. You can give the same man who has the same BMI and the same height and weight, etc., androgen deprivation therapy of some sort, and the neurocognitive impact and the metabolic impact can be quite different. And that is vexing when you're trying to provide a recommendation for a patient who might be on the edge of metabolic syndrome, etc. So I think, although there aren't tools right now for that prediction, I think there's an opportunity for that. And the complexity of decision-making increases as the patient kind of goes through different lines of therapy. And, one of my contentions is that for the various clinical trials that are going on, particularly in advanced stage, one should be considering them at the kind of the N-2, if N is the last line of therapy, or L-2, so to speak. So you want to consider them for certain clinical trials before they've exhausted everything, before their bone marrow is completely shot, etc. But the cognitive load to kind of keep that all in your head if you're a busy clinician is kind of hard. So I think there are significant opportunities for AI in the broad sense of the word to help in this space.
Yeah, absolutely.
Because
there's so many data points. Yeah,
Paul,
sorry.
you talked about your patient journey, sort of concept. I wonder if you could share for our listeners a little bit more perspective on that.
Yeah, well, one of the things that the team that I lead, one of our drivers is to try to capture sort of a canonical data model of a diagnostic and therapeutic journey of all of our patients, and that takes a considerable amount of work. But if you can do that, and we'd like to actually employ AI to help us with that as we abstract, but then once you have all that data available, if you have all those data points, longitudinal data points, you can have clinical decision tools developed for the individual. And then for the population, you can start looking for those needles in a haystack, to what Adam is referring to, essentially finding patients anywhere along the journey who may be eligible for various clinical trials. And that's a much more efficient and patient-centered way. I mean, we talk about personalized medicine. What does that really mean? Well, it really means taking all those complex data points and trying to figure out what's best for that patient. And from a clinical trials perspective, it's, well, let's take this, we're trying to find needles in a haystack, and, we should be using tools to identify the needles so that we can then mine these larger and larger data sets that are very complex, but that they're longitudinal, right? There's no snapshot in time. And it's also the real complex part, as Adam was sort of alluding to, is it's the context of where a patient is at any one point. You have to know where they were, everything they've gone through, every therapeutic pressure that they've been exposed to, understand where they are, layer in maybe patient-reported outcome measures and some other predictive tools so that you can sort of make some guesses as to where they're going. And that may also help you sort of define various cohorts. The cognitive strain is, Adam, I think, so it's such a perfect term, because as a busy clinician in real time in the clinic without aid, that's for sure.
Yeah, Adam, I know this is something that we've talked about before as well. So I'd love to hear from you. What does a well-visualized diagnostic and therapeutic journey look like? What's in it, and then what's usually missing today?
Wow. I guess, again, this is my opinion. I haven't done the focus groups of all different physicians, but I'd like to know of all the data that's before me and that's been collected in the EMR relevant for that patient and potentially family. And that would also include social determinants of health and financial talks and how far are they traveling and stuff. So what are the relevant pieces of data I need for this decision point right now? And also, when Paul and I see patients, we're not only considering this time point, and Dr. Showalter, and this time point for point of care, but we're also thinking if plan A, B, or C doesn't work, what's our next plan? So most of the data that's currently presented before us, at least before me, is not so useful. And then it's frequently displayed in a numerical or tabular format, which is frequently unhelpful. And it also doesn't tell me about all the variation of kind of the human operator part. We could take the same PSMA PET and show it to 20 nuclear medicine radiology folks. We might get 21 different, reads on that. Now, there'll be a bell-shaped curve, but so there's a lot of, I think for Gleason scoring and stuff is less of an issue, and there are numerous companies that offer AI opportunities related to the pathology. So to help surface what's relevant now, keep me informed as to what may be relevant that's upcoming, appreciate sometimes, much like that frog in the hot water analogy, sometimes I become immune to trends because they creep up on you. And then I realize, oh, I wasn't really paying attention to this, and this patient is really progressing faster than I may have fully appreciated. And then the ability, I'm fortunate I work in a practice that there are numerous people I can sidebar and get pick up the phone, et cetera. But not everyone has that luxury depending on where you practice. And so having a colleague to query from an AI perspective that's, there's some guardrails on to reduce the hallucination, I think that would help complement my workstation.
Yeah, I like that you're sort of starting to think in this exciting era where we have AI powering technologies at a faster pace. I think you're already starting to highlight some of the opportunities to solve some of these challenges with these technologies. And maybe, like Paul, I'll point this to you first. I'd love to hear about what you're seeing in terms of clinical practice for how these new technologies could help. Like, what's a good example of what you're seeing make an impact at your practice?
Well, the most palpable for me, again, viewed through data lens is optical character recognition and natural language processing, because no matter what the sort of scope of your practice, we're going to be using some elements of this. Some of these things already exist, where some level of data abstraction, trying to turn unstructured into structured data into whatever EMR you're using, that's a fundamental sort of a fundamental task. And so leveraging that is really important. But then you have, do you have a human in the loop or not? What acceptable mistakes and flaws and error rates are you willing to allow for? And one of the things that to back up just a little bit, because one of the for large groups like ourselves is we're trying to do population management, and this happens in academic institutions as well, but particularly in my scenario, in our sort of ecosystem, what can happen is you can get flawed data, either erroneous or old or conflicting data gets embedded into the chart. And I always talk to people about, an analogy is, or a example of this is in the U.S. Army, they use the caduceus, the two snakes on the rod. That was actually a mistake made like about 100 years ago. Caduceus was for like mercury. The actual rod of Asclepius, which is the one snake, is actually the symbol for medicine. And so that mistake that they made, 100 years ago, that symbol got embedded and is entrenched, right? So you'll see the U.S. Army Corps still uses the wrong symbol. That's where bad data gets embedded into a system. And with oncology, that's really dangerous and problematic. And that's in sort of inevitability. But you then using AI tools to help weed that out is really important. And again, this function of unstructured, getting that into structured elements, that's what we're working on now using OCR and natural language processing. That's going to be as basic as, the air, breathing air, like that's going to be sort of fundamental to all of our data processes, both large and small scale. So
Yeah,
that's something right now we're dealing with.
I saw my physician yesterday, yearly preventative health, whatever. And he, like many people at our institution, is using an ambient scribe, which has definitely improved people's lives. But he warned me ahead of time, knowing that I spent a lot of time in the AI space, that it occasionally makes up stuff. And it doesn't have a way currently to kind of clean up the stuff that it made up. I'm not sure, whatever, in the current version. And at the end of our visit, he showed me what it did. And he felt that in a couple of areas when I was describing stuff that was going on in my health, like it made extrapolations that kind of weren't there. So, all this technology is only as good as the stuff that you're putting into it. And that's why Paul's comment is fairly underappreciated in the field, except for those who are really deep in the AI space. They know that 90% of the time we spend just cleaning up data.
Well, and I'll say the ambient scribe is, to Adam's point, as a clinician, I cannot, and I've only had it for about 6 months. I cannot fathom the idea of seeing patients now without it, but I have a healthy appreciation for its shortcomings.
So Adam, you had a quite an insightful perspective, which I found to be pretty intriguing last time we spoke. You said that physicians perhaps are being more critical of AI than of their own colleagues. How does that intersect with this discussion that we're having now?
Well, it relates to the whole, most people are not, everyone thinks, first of all, they're in the top 10%, and statistically, it may not work out that way. People don't want to acknowledge that 50% of Harvard's class is in the bottom half, right? So, I don't think there's enough training in the medical system to understand, the behavioral economics, the cognitive biases that Amos Tversky, Daniel Kahneman, Richard Thaler, and many, many others talk about. There's a great podcast There are a number of podcasts that focus on behavioral economics that I strongly recommend, maybe in the show notes. So I think that's one thing. And then physicians aren't trained to think probabilistically. And that's a real challenge. There's a great book by Annie Duke, Thinking in Bets, where she really, it's not about physicians, but it's trying to think in decision making, try to think more probabilistically. So inherently coming in, there's this, tradition of training in medicine for a long time, and how to teach people where there are shortcomings in the way they approach problems is challenging. There's a beautiful example in that book that I mentioned, Random Acts of Medicine, where they refer to a paper that Bapu Jen is the last author on, and it refers to behavioral heuristics in coronary artery bypass surgery. And the framework is they looked at Medicare, Medicaid data, let's say 250,000 people in the United States over a certain period of years. And let's say the guidelines and recommendations are that above the age of 80, you shouldn't be operating on someone who is in a particular, shouldn't be doing CABG, let's say. Now, theoretically, the person who's 79 and 50 weeks and the person who's 80 and 2 weeks, they're basically the same person, right? But the way physicians approach these kind of rigid things is quite different. And what they showed is that within 2 weeks of their birthday, there were significant differences in who was operating on, et cetera. I made this mistake myself. I saw a patient this week, and the patient was, I said something about 75 or 74, because that's what I remembered when I looked at the EMR, header. And he said, oh, I'm going to be, whatever, 76 or 80, I forget what the number was, next month. And it was like, oh, now would I treat him any differently? In that particular case, no, but this left-digit bias has a huge influence in all of our thinking. And I don't think it's enough, and there's some data on this. It's not enough to even be aware of these biases. Like, if you don't have a mechanism to counteract or counterweight these biases, cognitive biases, it's just not, it's not enough to like remind yourself, look, I could have all the great high density caloric food from Trader Joe's, and if I just say, oh, but I shouldn't have this, like, no, the way is to move it away from my, from my field of vision, etc.
It's really interesting. And as you were talking, I was thinking about that magic age of like the age 70 cutoff to talk about prostatectomy. And, I could show you from my own clinic, someone who's 65, who hasn't been taking care of themselves, and someone who's 75, and you would reverse the order for who should have surgery, of course. And I'm curious, Paul, what are your thoughts overall about what AI can do in terms of, I think of this as really like a risk stratification or patient identification problem. So.
No, I think that's exactly right. I think we know this. Adam keeps referring to heuristics, which I love because I'm familiar with some of those books, and it does show you. If you start really thinking about it, you see some of the shortcomings in how we just as a human mind as we approach things. But we know that, particularly as surgeons, right, that there's a chronologic age and there's a physiologic age, and trying to understand if there's a particular delta between the two is not easy. We have a couple basic tools that would be some phenomenal area for AI to do, which is to ingest a bunch of the background data on a patient and to use modeling to suggest this patient is younger than stated age or older than stated age, or try to make some life expectancy predictions. I will say one of the things is I was listening to Adam that is so real and important right very now is when we are ordering PSMA PET scans in particular in newly diagnosed prostate cancer patients, just for instance, that pre-test probability, right, is so important, right? Because the nuke med doc has to look at the scan and make a call. Oftentimes there's a gray area. That pretest probability, what are the underlying facts to go along with it? Oftentimes that's not there. And I think when the molecular imaging is going to be fused with a lot more robust clinical data, and then there's a lot of data in a PSMA PET scan, for instance, SUV values, max mean, total volume. You're not going to be able to read part of a PSMA PET scan without AI, as far as total volume lesion analysis. All of that, in theory, can be used to help us use these tools better and apply it better. That's what I'm excited for, and also frustrated that we haven't, we're not exactly where we should be. Another example that I'm starting to use is a company that's it's an AI-based plaque analysis. As I know, I'm just a urologist, but a lot of my patients are, older, have coronary artery disease. So we know that we screen for that, for erectile dysfunction, and or if they're going to be getting androgen deprivation therapy. And the level of detail on the analysis is fairly mind-blowing, and it's non-invasive testing, and certainly couldn't be there without AI. So if I'm seeing that in that one realm, I can only imagine as these technologies evolve, again, molecular imaging, pathology, prediction of underlying, genetic changes that are not being seen on an H&E slide. This is the stuff that, we're being hit with, and I think this is going to change the face of how we practice even this year, let alone the next 5 years.
Yeah, and I'll just mention with the PSMA PET, Tim, one of the issues is it may be read as like very low SUVs, and that patient really may be in a neuroendocrine transformation.
Correct. Mm-hmm.
But that's not going to be fully appreciated by the person, usually radiology or nuclear medicine. So, and really when someone lights up with numerous lesions on a PSMA PET, I'm most interested in knowing, if this were available, which lesion is the one that's going to be responsible for future metastases, because there may be metastasis-directed therapies at that. Now, I think the field is starting to peel back the layers to figure out which of the mets are the most lethal mets in the lower metastatic burden patient, but I think that's the potential. And just to show how prescient Paul is, in the world of proteomics, blood plasma proteomics, which I also work in with a startup, you can now show, taking a blood sample and analyzing the proteins, how in a particular patient or in populations, they've done this in the UK Biobank, patients' organs age at different rates. And you can show how that differential organ age gap predicts very confidently for neurodegenerative, cardiovascular, and other diseases. So there may be other ways.
The picture of Dorian Gray looks great on the outside, but your test would be able to show he's 105 on the inside?
Well, we know already that some people are like super agers or whatever the longevity thing is. I mean, thank God my mom's 95. She can do full splits front side. She's independent. She's quite active. We know patients can be organ aging at faster rates in multiple organs as well, and we've taken care collectively of those patients. So, it's not part of the standard of care, and it's not commercialized, but it's a very active space, now. And that's just one thing you could do with that blood sample. There are some other things you can do as well, but it's like here now. It's not like futuristic.
Yeah, I just want to call out, it's pretty amazing to hear two experts in like prostate cancer and GU oncology talking about much more general health applications of AI. I mean, we're hearing about cardiac screening and organ aging, and it's really, interesting to see that a lot of these insights and the fast pace of technology is enabled by AI. And it's really kind of expanding the perspective. Feels obviously like we're at an inflection point for AI in healthcare. I'm curious, maybe to start with you, Paul, like when you have all these options out there for AI, there can be a risk of overdependence on AI in terms of clinical practice and how that information's used. How are you thinking about that at the level of your practice environment?
Yeah, I mean, that is actually the thing that worries me the most is we become sort of blindly dependent on something, particularly if it creates a path of least resistance, right? Particularly, in our practices, we're busy, we're being bombarded with things, and I think that's a natural tendency. I preach to my group and to my data team. It's a trust but verify. If I can think, I'm quoting Ronald Reagan. That's where I think that healthy caution and skepticism, I think, needs to be built in. And I think one of the things I'm sort of interested in is self-learning systems, right? That are that continue to improve over time. That's the stuff that I'm interested to see when the technologies come and they start off kind of rough. And if they can, particularly with the human in the loop, with us sort of nudging it, correcting it, that it can self-teach or self-correct, I think that's going to be an exciting thing. But yeah, I think keeping a healthy skepticism about what AI is presenting us, I think, is going to keep us from falling into traps. Because I think when clinicians, particularly your average Joe doc, if he or she is led astray by a technology, they then become sort of very critical, and I think we mentioned this earlier, get turned off. And I think that's the risk that AI-based companies need to be cautious about, right? Overpromise, under-deliver is always a worry, because then there's the backlash.
Yeah, I appreciate Rebecca asked me a question that I didn't answer her. But thank you, Paul, for bringing up the issue about trustworthiness, right? Yeah, so there's a group of physicians who trust the AI more than people. They'll trust the Waze or Google Maps or Apple Maps or whatever more than the person next to them, who may know the area very well. And we've all encountered those types. And then there are people who are incredibly distrustful. So I think both the academic community that's involved in this space, the commercial vendors, all need to be part of this ecosystem that, one, it's on the education side, and two, what's the data that went into that allows us to trust it to some degree. No one's talking about replacing physicians. And everyone has a different, there's a phenomenon with people that they like to, even though the computer, the technology, the robotics might do better than, they like to have some input, and there's some work from various business schools about how much of that input is before you mess up it too much, whether it's a 10% in terms of tweaking the dials. But if you don't have the human in the loop, you'll lose the trustworthiness, you'll lose the engagement, it won't be part of the workflow. But so we know that too much human in the loop may not be the best, and too much automation may not be the best. And I think there's a lot of research to figure out what's that sweet spot.
Yeah, I think exactly. We're trying to figure out how good is good enough, right? What is the threshold for which we should trust this? And so along those lines, what level of evidence of validation do you think builds that appropriate trust?
Kind of depends what the stakes are. There's always a risk benefit, kind of ratio. If the stakes are low, fine. I mean, one thing that's not fully appreciated that Paul and I alluded to is when people complain about AI, they don't appreciate how bad the decision making is, amongst the humans. So they don't even understand like where's standard of care right now, and standard of care may not be so great. For me, when Alan Parton came out with the Parton tables in like I think 1993 that talked about probability of extracapsular extension and seminal vesicle invasion and all these things relative to Gleason and PSA, I thought this was like the Rosetta Stone.
Mm-hmm.
And I was a resident at Sloan Kettering at the time. And for me, it totally transformed the way I viewed patients. Because previously it was a digital rectal exam, not so helpful, a lot of variation. It was a PSA, and because we don't know in that PSA how much of it relates to cancer and how much it relates to normal prostate. And it was a Gleason score that was like, at that time in the 90s, there was a lot of operator variance around the country. Pathology community has done a great job since then about leveling the playing field and making sure there's more uniformity. And I thought the decision-making was like terrible. And it was all based on, based on how I trained. And it was like both in urology and radiation oncology. And I thought the Parton table was like, wow, now I have truth. Well, it was the best of truth at that time, but that was truly transformational, because no one had collected 3,000 patients and mapped out all this stuff and about what would happen after a prostatectomy, and that was like amazing work, and it only got better after that.
Thank you. I think we're approaching close to the end of the conversation. So I think at this point, we're gonna take a look ahead. Rebecca, do you wanna move us towards some future looking thoughts here?
Yeah, sure. Would love to hear from both of you all. So as you look out 3 to 5 years, right? We've all come to the conclusion we're at this inflection point. AI is here. How do you think it's going to fundamentally change how your patients are being treated? Adam, let's start with you.
I think appreciate that we're getting better cures. People are living longer due to advances in cardiovascular medicine that Paul alluded to in other areas. I think we can take a more holistic view of the patient than we have in the past. I'm very sanguine and positive about the opportunities. I think the ability, we had some visitors from Rwanda today, and they have some challenges in delivering healthcare, but I think the ability for AI to democratize this type of information expertise throughout the globe is like amazing, that you couldn't really do so well before. So I'm quite positive. I think there is a new type of physician who, whatever the discipline is from a training perspective, the physician who's fluent or at least literate in this space, I think will be able to advance the field even more. And I strongly encourage every medical specialty to develop training in this area.
Great, thanks. Yeah.
Sure. So there are sort of 3 buckets, not mutually exclusive and certainly not exhaustive, but in practice, right? One of the things that we are in desperate need of is efficiency in workflows. I mean, just as basic, just like running a business, because in the non-academic world, we are essentially running a business. And I think AI applications that will be helping, say, for chart prep and basic functions of, reducing, we have limited bandwidth. And so any tools that will help us do prior authorizations, fighting, insurance companies, charting, chart prep, those sorts of things that are the nuts and bolts and the very non-sexy things that practice has to do. I think AI is already making some big inroads there. I think that's my business going to rely on AI in those regards. I think personalized medicine is, up till now is tiddlywinks compared to AI driven personalized medicine. I think it's going to make us look very rudimentary just even from a couple of years ago. So I'm looking forward to those advances. And it's drug discovery and exploration of biomarker discovery, because we are, we depend on these things, right? So it's drugs and biomarkers are, drive cancer care in many ways. And the accelerant that AI can promise in that regard is sort of my creativity in my brain is too limited to even make guesses of where we're going to be 2, 3, 5 years from now. And that's going to be driven by AI. But those are those three things that I'm sort of looking forward to, is having my practice become more efficient. I'm going to be delivering more efficient care, nuts and bolts. I'm going to be able to actually deliver on this promise of personalized medicine. And, smarter people than me and companies are going to be delivering to me technologies driven by AI that will be paradigm shifting. So those are the things that I'm looking forward to the next 5 years.
Yeah, and I'll just add to, what Paul alluded to is we're probably only using 1/10 of the data that's available to us. So
Sure.
the ability to repurpose, EMR data, imaging data, behavioral data, PROs, patient-reported outcomes that Paul mentioned, and other things, there's so much data that we're not using that's available, but we just don't have the right tools.
Thank you both, Doctors Adam Dicker and Paul Yonover. I was looking forward to this conversation and did not disappoint. I really appreciate you sharing your insights with us. It's been a pleasure.
Yes, thank you both.
Thank you for having us. Thank you for giving me an opportunity to introduce the picture of Dorian Gray. So appreciate that. My favorite book.
Thank you.